Okay. Hi, everyone. Welcome to our multi-heart lecture series. It's a great pleasure to have today Dr. Leslie Shaw, who will be speaking about atherosclerotic imaging to guide risk detection in the COVID era. It's a real honor to have Dr. Shaw here today. She's a leading outcomes researcher with a main focus on cardiovascular clinical diagnosis of ischemic heart disease. Dr. Shaw has published a lot of papers. She has over 800 publications. She has been ranked as the top 1% of clinical researchers with the most highly cited publications. She has an H index of over 150, which is a lot. She has received a huge number of high achievement awards, including the Simon Duck Award for Academic Excellence from the ACC, Women's Day Red Dress Award from her scientific contributions to women's health, gold medal from SCCT, and many more. She also has served as an associate editor for several journals and now serves as an executive editor for JACC Cardiovascular Imaging and as an editor as well for JACC and Circulation. She's the past president of the American Society of Nuclear Cardiology and the Society for Cardiovascular Computed Tomography. So not only in CT, but in cardiovascular imaging, you're a great pioneer. So I'm willing to learn from this. I can't wait for your lecture, and I'm sure everyone else feels the same way. Thank you again.
Thank you so much. I really appreciate it. It's really exciting to be speaking here today, and I really look forward to the discussion around atherosclerotic imaging. We're embarking over the last year in a lot of collaborations between Sinai and Monty Hart, and I think it's thus far it's been very productive. Would certainly love to increase that even more. Okay, there we go. So today I'm going to talk very briefly about the current evidence with CT. I know this is a very sophisticated audience, so I don't want to go into too much detail. So I'm going to highlight the evidence, particularly from the recent chest pain guideline. But most of the talk I'm going to spend on imaging of atherosclerosis, and then I'm going to talk at the end about therapeutic intervention, which is our ultimate goal. We're not there yet, but I want to kind of highlight some of the areas and some of the data that are available. And then for the latter part, talk about our ongoing collaborative project looking at atherosclerotic imaging using CT in patients who have had COVID. And I think you can probably get an idea that we'll be seeing if that inflammatory milieu related to COVID actually impacts the progression of atherosclerosis. So there are lots of different recent expert consensus documents and guidelines. This is just one that you could look at from SCCT. But I think the broader one in cardiovascular imaging focuses on the use of coronary CT, and this just gives you a gamut of different from normal to significant stenosis, and what we're looking at in terms of detecting a normal all the way to mildly abnormal presence of atherosclerosis. You can see calcified plaque here in white, but also significant obstructive stenosis. And the guideline, which was recently published, is very controversial. It took 4 years to write. I was a part of this and was responsible for organizing, lucky me, responsible for organizing all of the kind of non-invasive approaches on this. And I really think it was quite revolutionary in the area of cardiac CT. There are a lot of randomized trials. I'm just showing you one on the left from the Scott Hart trial, the 5-year results showing a reduction in major cardiovascular events, coronary heart disease and myocardial infarction with CTA as compared to the standard of care. In total right now, there are about 12 trials using CTA as compared to the standard of care or stress testing in the emergency department, and another 9 trials using stable chest pain. And the stable chest pain trial, as an example, is the Scott Hart. The result is what you saw in the ESC guidelines on the right hand and the top is many class 1 indications for the use of functional imaging or CTA. Historically, this would have largely been the domain of functional testing. And CTA in the ACC guideline, ACC-AHA, has several class 1 indications, including class 1A indications for suspected ACS, stable chest pain, and with and without a suspected coronary disease, with and without suspected or known coronary disease, including a focus on non-obstructive atherosclerosis or non-obstructive coronary disease. Here you can see some of these algorithms. Myself and Ron Blankstein actually came up with most of these algorithms that are in the guidelines. So if you don't like them, they're my fault. What I think we try to do is to give you some way of working up the patient. And sometimes it's very difficult to make this so simple. And what you can see now, and clearly different from the prior guidelines, is now CTA class 1 indication at a level with stress testing, providing an option, an equivalent option to the use of stress testing. So this is a big deal, largely for a large population, particularly those presenting for the evaluation of chest pain and suspected coronary disease. Now, the ESC guideline really kind of had this focus that CT was for kind of lower risk patients, which is the traditional approach, and the use of stress testing for ischemic to induce ischemia so that you could guide decision-making around the use of coronary revascularization. I think we're seeing that evolve in the ACC-AHA guideline, where now you have equivalent options. Surely there is an option in this approach to doing CTA first, understanding the extent and severity of coronary disease, and if necessary, doing a follow-up stress testing or the use of fractional flow reserve. The other way around, when you use stress testing as a first approach, so many patients may have potentially false positive tests, or what we see is go on to having invasive coronary angiography largely, but the result has been a high rate of normal coronaries. So using a low-cost, non-invasive procedure like coronary CTA is really a viable option, and one with a tremendous evidence base to support its utility, both in European and US guidelines. So that's kind of your whirlwind tour of CTA as you're using it right now for clinical applications. And we really are on the precipice for all of you to use CTA, not just for understanding the extent and severity of an obstructive stenosis or the extent and severity of multiple vessels potentially with obstructive stenosis, but understanding atherosclerosis as you can image it on a coronary CT angiogram. I am not a physicist, and I'm going to give you kind of the basics of how most of the quantitative software packages are developed and used. And what you see in this red box is a center line on the left coronary, left circumflex and LAD coronary artery. That center line is an automated center line, which is projected down the coronary arteries, which is the first step in automatic image segmentation. And of course, this is a computer-generated, automated, generally using some forms of artificial intelligence. And you probably are already thinking about ways that these kind of automated approaches can go awry. We've seen these center lines that go down side branches, center lines that go into the myocardium and curl around the endocardial border, things like that. So our first step is understanding that the center lines will not necessarily be perfect, and therefore every kind of piece of software that you all use in your clinical practices or you look at are certainly something that is not going to be this magic bullet. The programs do require expert readers to actually look and see how the center lines are, how accurate they are. But from the center lines, you get a tracing of the vessel wall and the lumen. And then what's in between, as you can see here, is atherosclerotic plaque, is particularly in this case where you see that the artery is positively remodeled, as you can see in that center box with the arrows on there. And so we see that there's plaque within that vessel, but how do we understand the morphology of that plaque or the composition of that plaque? And here is a slide from a recent article that we published in JACC Imaging, where you can see that for most programs, not all of them, they look at the Hounsfield units or the radio density, how black or white the density is of the plaque. And it is across a Hounsfield unit, a range of Hounsfield units. And what you see are two separate types of plaque that gets categorized. And this is generally how the plaque is categorized. On the left-hand side is non-calcified plaque or softer plaque, lipid-rich plaque, and it can be categorized into fibrous, fiber fatty, and low density. Now, low density, unfortunately, throughout the papers is either called low density, low attenuation, in some cases necrotic core. We don't really know it's necrotic core, so that's where it gets a bit challenging. And then on the right-hand side, you see calcified plaque. And of course, what's nice about this is through these kind of Hounsfield units ranges, we're able to identify both the unstable plaque, potentially, if I can call it that, and stable plaque by looking at calcified plaque. There is, again, a caveat to all of this, is that all of these densities are also, they're also there with other types of structures that are surrounding the coronary artery. Fat, for example, is negative 100, water is 0, muscle and soft tissue is in there in terms of having a Hounsfield unit range of about 40 to 50. Contrast is probably the biggest challenge overlying. It has quite a range of Hounsfield units in it that can impact the classification or the categorization of plaque composition. And of course, what's fascinating to me, I always think I'm fascinated by calcified plaque, is that when you get these very dense calcified plaques that have a Hounsfield unit of over 1,000, we like to call them 1K plaques. I don't know how much it's caught on, but it's interesting that is a similar it's a similar range in Hounsfield units to cortical bone. So if you think about that in the coronary arteries as a marker of stability, I think it's fascinating. So this is just one program. This is Elucid, gives you an idea of what I'm trying to look at one that I don't know if you've been able to see. You can see on the left main and left LAD, on the far right example. And usually you get a program that will give you like diameter stenosis, the percent or the actual volumetric measurements of lipid-rich, in this case, or low-density plaque, as well as total plaque volumes, which are also important. And as well, I think a measure that has often been used is this percent atheroma volume, which just gives you an idea of how much of that segment or that artery is containing plaque. So interestingly enough, that's the PAV, or percent atheroma volume, is something has been used, particularly in looking at comparing serial studies, particularly with treatment differences. Now, one thing just to remember is that usually somewhere between thresholds of 1.5 to 2 millimeters, you're not going to be able to, the scanners and the automated software interpretations are not going to be able to image quite most of the distal coronary segments. Now, many of you are thinking, well, I'm most interested, the meat of the matter in atherosclerosis is proximal, a lot of the acute coronary syndromes. But when you think about volumetric measurements, you're going to have to consider that your total plaque volume may not really be a measure of total plaque volume because of some of these issues of not being able to image all of the coronary segments. So issues around dominance will affect how much of it is measured, as well as women who have smaller coronary vessels. You may not be able to image all of that. And this is, again, something for consideration as you're looking at your interpretation. But now, so that's now you're all CT experts, at least as much as I am. And so then now what are we trying to do though clinically? I think this is the more important question for us. Well, one of the factors is we know is that if you had a prior angiogram throughout the decades, 70s, 80s, 90s, and even through contemporary cohorts, we know that patients who present with ACS, that roughly speaking, this is fascinating, roughly speaking, about 2/3 of those patients had a prior non-obstructive stenosis. So that is the potential culprit vessel that we're trying to see if we can identify precursor features and what is making it progress. So if you look at the cartoon from a review paper by Amir Ahmadi, you can see that on the top, you see progression, particularly progression of that lipid-rich necrotic core. Even though the stenosis didn't change, you then saw an expansively remodeled artery, which is going to expansively remodeled or positively remodeled before it negatively remodels again. So that's fascinating for us. And we would therefore be able to image that with CT. The whole goal, though, is not to watch people progress to ACS. Obviously, the goal is for us is to identify those at high risk of ACS, initiate very preventive care, and to stabilize that plaque by shrinking, particularly that lipid-rich portion of the plaque. And that's really kind of our big picture view, 3,000-foot view of what we're trying, where the field of CT is going. And I think as you look at this, this is another figure from our recent paper from one of the fellows here at Sinai, looking at what you look at when you're looking at either pathology on the left or invasive imaging. You're particularly able to see kind of the fibrous cap and potentially identify how thin that fibrous cap is. There are other measures that you might, from pathology, microcalcification, intraplaque hemorrhage, things like that, that you might be looking for, a pathologist might be looking for, or an invasive imager might be looking for. CT, we cannot image all of this. We particularly don't have the resolution to look at the thickness of the fibrous cap between the lumen and the plaque. In some cases, people have talked about looking at a napkin ring sign, which is really a central area of low density that it abuts the lumen, which is a critical component of a plaque rupture, and that ring has a higher density to it. We can't, with that, we don't see that often. I think the most of what we're going to see is perhaps some spotty calcification. We can get the volumes of low density plaque, and we can see how positively remodeled that is. So that is, so we do have to, I hate to say this, kind of dumb it down from because of the limitations of CT, and we'll see these perhaps start to improve once the technology improves, but it is an important consideration as we're looking at what we're doing with CT. So what are our main targets? Well, volume of high-risk plaque, the low density, low attenuation plaque. Is it positively remodeled? Total plaque volume, where is it located? How diffuse is it? And inflammation. And I'll talk about perivascular fat a little bit later as we go through our discussions, particularly around COVID. We've published some data a few years ago, just comparing people that progress to ACS versus those that not. This is not surprising to you because we've just already talked about it. Most of the patients who progressed to ACS had a non-obstructive stenosis, and the big factors that led to understanding ACS risk was the volume of low density plaque and fibrofatty plaque. Those were the two highest predictors about when you saw a high volume of low density plaque, it increased your risk of ACS by about 40%. Also, spotty calcification, it was also a strong precursor feature of ACS in this iconic registry. Again, we look throughout these signals here to understand. This is just kind of a capping up this to look both at pathologic signatures here, the necrotic core, low density, and fibrofatty. But as you move along in this group of figures, those areas that go to the right become more markers of perhaps stability with calcified plaque. And you can see that there's no difference, if not a protective measure, when you have very dense plaque. We believe the 1K plaque is a marker of how old that calcified plaque, because you can see over time when we have had serial studies that the density of that calcified plaque gets higher and higher and higher, and perhaps much more of a marker of stability. And there have been papers which have taken this to the next level, not a lot, I think, of very high quality papers. Here's a paper that was done through the Scott Hart trial, where they actually used Dominique Day's program to look at predicting incident myocardial infarction, had about 50 MIs in the Scott Hart trial, and they looked at the low attenuation plaque showing that when it was the percent burden of low attenuation or low density plaque was greater than 4% of the total volume, that was associated with increased risk of incident myocardial infarction, as you can see by this incident curve here. But what was interesting is if you add in the presence of non-obstructive disease plus this degree of low attenuation plaque, then that risk of myocardial infarction increased almost 7-fold. And interesting, if you had non-obstructive disease, but no, you did not have that low attenuation plaque, their burden, you weren't even remotely had an increased risk of incident myocardial infarction. So that's a fascinating piece of the equation. Of course, Mears-Ferencik, this is now getting to be about 5 years old, but it's really one of my favorite studies. And even over a short period of time, the presence of these high-risk plaque features, is it positively remodeled? Is it low-density plaque? And is there this napkin ring sign? Even over a short period of time, such as 3 years, 32 months was the average follow-up, you had a really 3-fold higher risk of coronary disease events. But again, what's really fascinating, and I know what you all are focusing on with a lot of registries, is to look at unique populations, right? And so what we saw in the PROMISE trial data is that these high-risk plaque features were more predictive in women, more predictive in younger folks, and more predictive in patients with non-obstructive disease. So, which is really fascinating when you put it all in the perspective, because it's hard in stress testing in these populations, right? Non-obstructive disease is not often going to be detected with stress testing. So here you see high-risk markers that really predict in a very tough patient population. And so we can, that's something that we can truly rely on. Here's a paper again that from our collaboration with Cedars, and this is Dongyi Han's paper in JAMA Cardiology last year, where he looked at kind of simple measures, right? We know that the plaque starts proximally and works its way down. So Dongyi looked at the distance from the ostium to the lesion, looked at lesions at bifurcations, perhaps areas which would be more prone to shear stresses which may accelerate progression, as well as vessel tortuosity, and showed an increasing hazard for clinical events based upon what he called these geometric characteristics. I might also add some other papers which came out of your own Box's group. Actually, this is from Max, his son, where he looked at the proximal location. Certainly, there's data showing the left circumflex has less atherosclerosis. And so Max looked at the LAD versus the circumflex, showing predictable events that a lot of the risk is in the LAD, looking at eccentric shape, things like that. I think we're really on the tip of the iceberg, though, with really characterizing or phenotypically or endotypically characterizing something that we could call as high risk. I think it was simple to begin with. It's becoming more and more complex. I have to add in FFR here because it also has an increasing body of evidence. We just saw presented some the EMERALD-2 data in the ESC from Bangkong Kwan Ku. Here's a paper from the advanced registry looking just at and the FFR's fractional flow reserve with CT is a modeled FFR from computational fluid dynamics, and just a simple, just a stratification by greater than 0.8, typical FFR threshold versus less than or equal to 0.8 from this large registry was able to predict the likelihood of cardiovascular death in an MI, and it stratified this very nicely from this paper in JACC Imaging a few years ago. Of course, I think ultimately, I'm going to talk a little bit in the next few slides about therapeutic differences potentially. Can we shrink that lipid-rich plaque? I mean, it would be ideal if we could really take some of these high-risk patients. People have family history of premature atherosclerosis, perhaps those persistently elevated LDLs, diabetics, metabolic syndrome, inflammatory diseases, preeclampsia. I don't know, lots of you all could come up with your own subgroup. And they did have a large, bulky, non-calcified plaque. Can we initiate some of these in preventive therapies including lifestyle modification, with the goal then of regressing that non-calcified plaque burden. And like that, that cartoon from Amir Ahmadi, can we see that plaque volume not only regress, but then stabilize and reduce incident ACS, which is ultimately the goal here. You know, there aren't a lot of trial results. Here's one from a few years ago. And I think that's actually good that there aren't a lot of trials. I realize that all of you would love to have saying, you know, we need to put up this patient on drug A or whatever drug that comes out. But the data, what's challenging is imaging, and we're kind of refining the interpretive standards for this. So we have to kind of wait a little bit for some of these. But this was an interesting trial, the Evaporate trial, published a few years ago now in ESC. It was a randomization to icosapent ethyl, omega-3 fatty acids from fish oil versus placebo. 80 patients were enrolled, 68 completed the protocol. We saw that the primary endpoint was associated with a reduction in a non-calcified plaque volume, both low attenuation fibrofatty and fibrous, with a total reduction in non-calcified plaque volume. Small number of patients, interesting. I think we can probably replicate the data, but it is kind of a groundbreaking trial. We've also published some data, and this is way too busy a slide for me to put up here, but I know this is from one of my fellows a couple of years ago, and I'm going to highlight this. So here is, we looked at serial CT. It was, somewhere around 850 patients. When we looked at using paired CTs about three years apart, looking at progression of atherosclerosis with patients who had statin therapy versus those not treated with statins. And if you look at both the low density and the fibrofatty plaque, you see that the patients on statins had a much greater reduction in total plaque volume as it relates to those compositional subgroups of low density and fibrofatty. Those were the results that were particularly important for this analysis. Also, I think what we're seeing is increases, not only those statin-treated patients, increases in high density as well as the 1K plaque. So specific subgroups of calcified plaque are actually increasing on statin therapies, which I bet that a lot of you have seen this when patients are on statin therapies and you see changes in a calcium score, for example. But what is interesting about this data is we used to think that calcification was just a passive process. We never thought it was a really active process and reactive to other types of stimuli. And here is a great example about how much there is kind of an adaptation to the milieu in trying to stabilize that atherosclerotic lesion. So for the next 10 or 15 minutes, I'm going to look at some novel research that really is ongoing, that I would bet that every single one of you have thought about in your head as we went through, particularly the heat of the pandemic, is what was going on with your patients and how in that all of your patients that you couldn't regularly see as you did prior to the pandemic. And so we're going to give you a little bit of highlights on COVID-19 and inflammation, which we feel is a core component potentially of accelerating atherosclerotic plaque progression, talk about inflammation and atherosclerosis, and then give you an idea of the COVID CT registry and what we're doing as a collaborative effort between our two groups. All of you know this. You don't have to know a lot about COVID, but to know that it is results in marked systemic inflammation with the infection, and the cytokines that were released with the SARS-CoV-2 infection, we believe may activate pre-existing atherosclerotic lesions and accelerate disease progression. And that whole kind of concept is not new to the field. I'm not reinventing the wheel or talking about something which is really potentially kind of groundbreaking. There is a lot of data on that acute coronary syndrome rates increase in patients who have coronary disease and then get the flu. There is also increase of coronary ACS rates in coronary disease patients following an acute infection. That's, often why, particularly for the flu, why the clinical practice guidelines for ACC, AHA recommend a flu shot for patients with coronary disease. There's a lot of data that following an acute infection, there's an upregulation of inflammatory cytokines, enhanced platelet reactivity, plaque destabilization, which leads to ACS risk. So we're coupling off of that. And I think Peter Libby termed this the echo phenomenon, which I really like. We're seeing that what goes on in the systemic circulation, can it actually echo into what's going on in the atherosclerotic lesion? And that's the basis for our investigation. And there was an interesting preprint that is in press in Nature and Medicine that just came out. You can see, if you look at the author pool, this is from NYU, but notably the cardiovascular pathologist Navneet Narula is on this. This is Jagat Narula's wife. She's awesome. But what they found was, and this is obviously at autopsy, looking at, and they were able to detect the SARS-CoV-2 viral RNA and see that it replicated in coronary atherosclerotic lesions. And they were showing this ability that the SARS-CoV RNA localized to the macrophages, which obviously is a strong inflammatory response that could form the basis for what we're trying to investigate. So this is hot off the press, August 15th, and we will see this again, likely in Nature and Medicine soon. Not really sure when, but should be in the next few months. So if you'd like to look this up, it's kind of an interesting. It's a very intense paper. A lot of the cytokine research is presented herein, but it's an interesting piece of the equation. There's also, there've been a few papers showing early risk of incident myocardial infarction, stroke, mortality, and not just overall other types of cardiovascular events, but certainly ischemic heart disease, acute ACS and myocardial infarction, in new onset angina for people who are infected with COVID as compared to non-infected individuals. And so I think this is another piece of the equation, looking more from an epidemiologic perspective, that we could be on the right track to seeing if we can measure with CT progression of coronary atherosclerosis. Here's another paper we had published just recently in JACC Imaging, trying to look at this inflammatory signal, seeing if there's more progression in people who had an elevated CRP. I don't think this should be any surprise to you that patients with an elevated CRP had much higher rates of progression, total plaque progression, so total volumes of plaque progression, but also the changes in non-calcified plaque, but no change in calcified plaque, at least in this analysis. So this is another piece using the CT techniques that perhaps an inflammatory signal could result in greater amounts of progression. Here is some data that I'm particularly fascinated by: perivascular fat. As all of you know, fat is very metabolically active. It's very inflammatory, and what we're trying to capture is to look at the pericoronary or perivascular fat attenuation. Again, a marker of attenuation in this example. This is some data from Karis Antonides in Oxford. And I think the figures on the left are a bit much, so I'm going to simplify this. If you want to look and if you want to understand what they're picking up in terms of pericoronary fat attenuation or this P5 signal, you can actually see up on the top row of images, you can see a culprit and a non-culprit lesion in the acute MI patient, and you can see the culprit lesion has a lot more red in it, a lot more inflammation. And you can compare and contrast it to the lower row of figures in the stable coronary disease patients. And so I think the idea with this pericoronary fat attenuation is that we do know that necrotic core plaque is a stimuli which perpetuates inflammation at the site of the culprit lesion. We know that from translational science and samples taken invasively, and it results in progressive disease states. And the whole idea of imaging this with CT is that coronary inflammation inhibits the accumulation of lipids in the perivascular fat. And you can image this with a compositional shift in these Hounsfield unit densities. And it's not just kind of looking at the pictures, but they've seen that cardiovascular risk prediction, that they were able to use this PFI in order to predict coronary disease mortality, but as well as incident myocardial infarction. So it's very, very interesting results. There have been a few external validations of this outside of the Oxford group, which I think is always important from a scientific point of view. These folks have not only just looked at the relationship to just incident myocardial infarctions and major coronary disease events, but they've used it in a manner serial, and particularly in immune disorders. And in this case, patients with moderate to severe psoriasis, which is pretty fascinating. And what you see is looking at serial PFI measurements. You now that you know how to look at these things, you can see at these scans on each one of these rows at baseline in 1 year. You can see much less red on the patients after they were given a biologic therapy to treat their psoriasis. You can see that the patients who received the biologics had a much greater shift in less inflamed perivascular fat, which is fascinating, which supports our ideas that immune disorders or immune dysfunction may be impacted upon in looking at the perivascular coronary fat. And then there was a recent article in Lancet from this group using what they call this radiotranscriptomic signature, which incorporates a number of other factors in addition to the Hounsfield units. And they did this in COVID, and they looked at routine pulmonary angiography. They were able to use that CT scan and looked at the radiotranscriptomic signal in the aorta, and as well as the internal mammary artery, which the internal mammary artery I think is interesting, right? Because it doesn't have that proclivity to develop atherosclerosis. So we're seeing a marker of inflammation in the fat around the internal mammary artery, which was associated with an increased risk of in-hospital mortality in those COVID patients, which is fascinating. The short-term outcome, it's a proof of principle, supportive certainly of their other types of work that is ongoing. And so that's the basis for the development of our registry. Dr. Garcia, who's on today, and myself and a few others were active in developing this registry to capture really what went on with patients during the peak of the pandemic. This is a map that shows the peak of the pandemic, the positive test results across New York City in surrounding areas. And where we're trying to capture tests and get an idea of patients and hopefully enroll a diverse patients, particularly those that were a lot of essential workers in this. So this is an exciting, we're just around 11 to 12 months into this. You can read through these aims as well as I do. I think we've gone through this. We're looking predominantly at how the inflammatory milieu impacts plaque growth, particularly non-calcified plaque. And then we're also going to be doing this PFI measurement to see if that adverse inflammation from COVID-19 actually impacts the fat. So patients have had a pre-scan prior to the pandemic, and it's a pretty easy study in terms of the patient's responsibility. They come back, have a second CT test. We measure, we do an ECG just to look for intercurrent silent myocardial infarctions, as well as we measure hsCRP and lipid panels. And the group at Albert Einstein has just really done a phenomenal job of recruiting, as have other groups. And I've known Dr. Garcia for a long time, and I knew he would just be amazing in this, and he is, which is awesome. And I'm truly hoping that this is one of many future collaborations between us. And I think this could really prove some very, very interesting results. And I think the impact of COVID on cardiovascular disease, I think this pandemic has been unimaginable. for all of us. And, I think the delays in testing and treatment could certainly prompt worsening disease states. Whether or not COVID infection prompts that even more is something we're going to investigate. Certainly, I think just capturing how the state of where the patients are today is an important message. If we don't see that COVID-19 patients are adversely affected by COVID, I think that's also a great message clinically for you and your patients to say, hey, listen, we've done serial studies and we don't see that your COVID actually impacted, or maybe selectively only those with severe COVID, like we saw in a recent preprint from Nature and Medicine. So there's a lot of really good messages that we could find here that are good. I always like studies when they're good either way, if they're positive or negative. It really, I think, is a good statement for all of us. I think that the field of atherosclerotic imaging is truly at the precipice. I know that you all are on the leading edge of this, publishing a lot of papers around atherosclerotic imaging and plaque quantification, which is awesome. Certainly, I think we need longer term outcome data. We need therapeutic trials to see if we can shrink that plaque with CT. And, I'm just putting a shameless plug in for the COVID CT registry. So it is a great collaboration. I'm hoping it is one of many collaborations, since we have such a great friendship between the two institutions. And I have such great respect for Dr. Garcia and his leadership there, and Leandro and others. And so I think it's awesome that we have this meeting and discussions, and hope that everybody on the call, we see 34 people. If 34 people could refer a patient for COVID registry, would be in great shape. I think this is my last slide. So happy to open this up for discussion.
Thank you, Dr. Shaw. That was wonderful. It's such a great and unique opportunity for us to have you presenting your data, telling us about your trial. And it seems like a great opportunity also. You show data on progression. But that's usually not covered by insurance. So if there are patients or that could be interested in this too. So it's an extra tool despite of the trial that you can get for free.
For free. The government pays for it. Your taxes at work. So take advantage. And we even give the patient $100 stipend, to cover travel, lunch, whatever they want, so that hopefully that can offset. New York City is really expensive to get patients come in. So the patient will get some help with participation.
Thank you very much, Dr. Garcia. We'd like to start with a question.
Yeah, first of all, thank you, Leslie, for joining us today. And, we have an open invitation early next year to have you in person, so you can come to our grand rounds and spend some time with our fellows as well. This was a phenomenal presentation, and you have certainly a brilliant career that we all admire and have been admired throughout the years. I wanted to maybe divert a little bit from the topic of COVID, although I think I want to reiterate that we're trying very hard to recruit, and that if your patient contact any of my colleagues here, asking if it's okay to participate, please say that it's okay. I'm calling them personally, and so far, most of them have agreed. So I'm very optimistic that we recruit quite a few for you. So you brought some very interesting points. First, that 65 to 70% of acute coronary syndromes are unrelated to an obstructive lesion. Therefore, patients are not being able to identify based on symptoms for screening. We know that calcium score only identify a small amount of patients that will also have an event. In fact, patients with a low calcium score up to 80% have non-calcified plaque, and patients with a zero calcium score up to 5 to 10% do have non-calcified plaques as well. And you pointed out very well in your slides that actual treatment increases calcium and actually, if effective, may decrease non-calcified plaque. So why do we use calcium score at all for screening? Why don't we go directly to CTA?
Yeah, I think it's a great question. I think it has a lot to do with the fact that it's cheap and easy to use, and the results are very reliable across a whole array of different types of CT equipment. We have probably my first prognosis paper was published, I think, 20 years ago in radiology. So we have a lot of data with it. But you have to be careful. We know that plaque, as it develops, it's non-calcified first, right? And then it calcifies over time. So there are very vulnerable populations that are going to have a large body of non-calcified plaque. They are generally on the younger side. And so you just illustrated the problem with using calcium scoring alone. And the other problem, and I think my 2 cents worth, is that as we evolve to using CT more for targeting therapeutic intervention, which is where calcium scoring is now in the guidelines, I see that as we move more into using really targeting the volume of non-calcified plaque, that maybe the calcium scoring will drop off over time, and then the CT may play a more central role as we see some more trials with preventive therapies, whatever they may be. I don't think we have to go to these super expensive injectables. There's a lot of evidence, for example, with ARBs, that they reduce these non-calcified plaque burden. We're embarking on some small pilot trials with ARBs. And would love to have you guys participate with us on that. I think I'd like to find drugs that we can use in our community. So happy to open these up. But I personally think, because of the limitations of calcium, and we know that you get a calcium score and it's 400, it's really kind of too late, right? Patients likely have, half of them to 2/3 have obstructive disease. Many have multivessel disease. We want to capture them early, so we get them on changes in lifestyle. And it was a little bit long-winded, but I see that I see a kind of a window where we may see things change. I don't know how you guys feel.
Yeah, thank you very much. Yeah, I completely agree. And the prognostic value of the calcium score in the lower numbers seems to be a lot better. So identifying early, I think, would be optimal. So please put the questions in the Q&A so we go through them. One quick question that I think is important. You showed some different prognostic data from Maros Ferencik, who will give a lecture here as well in the near future. That high-risk plaque has a higher prediction in female and the younger. Is this related, you think, to some disparities in treatment, or just that people wouldn't be treated at that time? What are your thoughts on it?
I think I think you see more natural history when people aren't treated, right? The disease is going to progress. And so our populations, whether they be, in East Harlem here or where you all are, that progression and that natural history is something that we're all trying to change. Absolutely that. But I also think is that in women and younger populations, any kind of plaque is going to be compared to, in that type of analysis, is going to be compared to very, very low risk patients, right? A 40-year-old who has a very low risk, any kind of plaque is actually going to exacerbate that hazard ratio or that relative risk. And I think that's what you're seeing as well, is that patient is at much higher risk, and they don't get the life-saving preventive therapies the way they should.
Thank you. Thank you very much. We have a question from Daniel Lorenzati. He says, thanks, awesome lecture. He mentions that the recent 2023 ESC guidelines on the management of ACS have downgraded the role of CCTA for ruling out ACS in intermediate risk patients based on the fact that CCTA has similar revascularization rates than invasive coronary angiography and a little bit longer hospitalization length. What are your thoughts on it?
I think, guidelines are hard, right? And particularly, one of the vulnerabilities to the evidence with the use of a CT in the emergency department or an ACS population is that almost all of the trials have largely looked at efficiency, getting the patient out, and near-term safety. It could be a month, 2 months. And none of the trials have established that the use of CTA actually results in an improvement in outcome. And I think that's where you have a lot of vulnerability if you put a group of 10 or 15 or 20 experts in a room. That, the hardliners will say no difference in outcome. Let's go with the tried and true invasive coronary angiography. Others will say, and you can take this another way, others will say CT can be very helpful in the patients who are on the lower risk side for getting them out of the ED. So I think there's a role for both, but I understand why they did it that way. And it's largely no difference. Even the recent Gray paper in BMJ, which was David Newby's group, I'm forgetting the name of the trial, showed no difference in death or myocardial infarction at 1 year. And that really hurts the trials. That really hurts people with trial design, as Mario and you all know, and others. You have to be really smart with the trial design. You create vulnerabilities that you see, and this creates the vulnerability for CT in the ACS populations.
Thank you very much. A question from Jay Chudo. He's one of our non-invasive attendings. We were talking about the use of CCTA in asymptomatic patients. His question is, if we can identify disease earlier, might we modify outcomes, and when should we start considering this, and what are your thoughts on inflammation, anti-inflammatory medications as well?
Yeah, these are all really good thoughts. I think our system, our healthcare system, is set up to respond to symptoms. It's not really it's disease based. It's not based on wellness. I do think, though, that there are opportunities where we might see that change. If you talk to some of the large payers, they are interested in averting this milieu of a lot of testing in a patient population and getting the patient more oriented towards prevention. And that type of approach, you just exemplified the values of it. But it will be a challenge. Where the trials that are needed in that space are going to need to be large, and they're going to need to be very thoughtfully designed. But I think, as all of us, every single person on this call today, the reason we like and love cardiovascular disease as a profession is we can do something about it for the patient. And that fits very nicely into why we're all so passionate about cardiovascular disease. And I hope we get there, because I think you're absolutely right, that we can create pathways for improving life expectancy.
Thank you. We have a question from Paulo Schwartzman, actually watching you from Brazil. He thanks you for the excellent talk, and he asks more about this management. He's asking, do the characteristics of the plaque actually change the management? Does it make a difference if you have 30% plaque with signs of high risk? That he's saying it won't change your management of stenting, but the patient will be managed the same way with medications. What are your thoughts on it?
I think that's a really hard question, and there's really no answer for it right now. I think you need to know where the plaque is within the artery. Does it abut the lumen? Then I'd be really concerned about it. Is it more distal to the lumen? We don't know thresholds. I think you can characteristically say a bulky non-calcified plaque burden, but I don't know how that's defined. And I think a good amount of 30% of that is it probably also matters how much calcium is within the admixture of the atherosclerotic lesion. I'm going to guess, like the evaporate, you just use a 20% stenosis, which I don't think is very helpful at all. I think we're going to, if you look at the literature, somewhere around 100 cubic millimeters of non-calcified plaque, and there's not much of it, the literature on this space, somewhere around 100 cubic millimeters of non-calcified plaque is associated with an increased risk of myocardial infarction, somewhere in that neighborhood. So if you had a proximal lesion, maybe proximal to mid lesion, that was bulky, 100 cubic millimeters is a big amount, maybe even 60 to 70, I don't know. These are guesses. These are 100% guesses that could make me be totally wrong. Somewhere around that would be a good threshold for initiation, but that has to be tested. It really does.
Yeah, I agree.
You guys chime in, please.
Yeah, no, I
So
also.
I was going to make a question comment, actually. Yesterday, one of the patients that I saw, I was in clinic, was a 44-year-old woman with obesity, other medical issues, and for management of diabetes, hypertension, dyslipidemia, and other issues. At some point, we are going to have to really take seriously personalized medicine, right? Now we have 4 or 5 different strategies to treat dyslipidemia. And if our patient has also diabetes, we have another 5 to 10 choices of how to treat diabetes. Wouldn't it be reasonable to take an imaging technology like CT with analysis of plaque as an endpoint and decide which patient is a best responder to one therapy versus the other?
100%. That would be really, really awesome. And I think there's a huge pool of patients who fit into that category. And I think that would be, developing this kind of, and we had a couple of papers around statin responders and non-responders, but we could come up with other strategies, with the more contemporary weight loss drugs. Do they impact the P5 inflammatory signal and things like that? And how do they affect accumulation of lipid-rich plaque, all kinds of things like that. I think that would be awesome. I think that would be a great understanding and very clinically useful piece of information.
I agree. At least for my patients, when they have a lot of plaque or these characteristics, is when I try to use more medicines, right? You can't put everyone on PCSK9 inhibitors. You can put everyone in 3-4 medications, but if you have a lot of disease, it could make sense, or high risk. And there's a question here from Seth that comes also in this arena. We talked about the CT at baseline, but what about progression? He says, does the increase on calcification on CT with statins reflect plaque stabilization of vulnerable plaque, or how would that affect your management?
Well, I think we did an overall view of looking at the changes in calcified plaque volume. What we still don't know, and part of it is how databases, the databases that are devised right now, will be inadequate to answer our questions 5 years from now. And that's part of the problem with research, is that we evolve in our thoughts and we don't, I think oftentimes we should, rather than looking at whole volume or volumetric measurements, we really need to find out what's going on a lesion level. I think some of these patients, you're going to see more calcification, but we don't know, is it outside of the very high-risk lesion? What lesions and what is developing in other vessels? What is going on in the prime high-risk lesion? We don't have an answer to that. And I think part of that is answering the question is it okay if your calcium score or your volume of calcium increases? Does it matter if you're primary looking at watching the prox LAD and they develop more calcium in the circumflex, things like that? I think are all part of this equation that we don't have an answer to right now.
There's a question from Robert Osfeld. He says, thank you for the wonderful talk. In general, in patients with severe atherosclerosis, the lemur remains relatively disease-free. Why do you think the lemur is maybe relatively protected?
Yeah, I wish I knew the answer to that. Certainly, it's an interesting question. I also, think that, even graft atherosclerosis is different than native, much more fibrotic. I think that's another area that is prime for research in that, is to look at the grafts and how we can understand graft closures and things like that that occur. But I'm not, I don't know if there is any kind of arterial properties that within the lemma, or shear stress differences between the natives and between the coronaries and epicardial coronaries, and as well in the lemma. If you guys can chime in with an answer, happy to. I'm just guessing.
What do you think, Dr. Garcia? Any thoughts on the lemma?
Well, it's definitely a great observation, and I obviously the lemma is an arterial graft, and it's connected to the circulation, so it's very different to an explanted and reimplanted vein graft. The harvesting techniques that are used for vein graft surgery are quite different. There's a big variety of ways of doing it. So, certainly it's definitely an important area for stalling.
Thank you. And we had the last question from Dr. Lorenzati that I think is a good question to close. What are your thoughts on plaque burden versus plaque features? Do you think you foresee one being more as a holy grail for prevention than the other one?
I don't like the concept of plaque volume. Because I feel like so many of the segments may be missing. It may depend on dominance, certainly sex, and certainly some ethnic subgroups may have smaller vessels. Some data suggest this. I think the characteristics of what goes on in a specific lesion, I think, is bottom line what clinically is going to be useful for you, and really identify what is going on, particularly in the proximal portion of the vessels, and create kind of these signatures that we see, that what the threshold is for non-calcified plaque, or is it sufficient non-calcified plaque to create a positively remodeled artery with a ratio of 1.5 or greater? Is that kind of simple measures that we can use, that I think would be ultimately the best way. How about overall plaque burden in terms of just the volumes of plaque, Daniel? Is that what you mean? I guess you can't
He's
talk.
saying the overall plaque, such as CAC or all the Leiden and on the different plaque burden.
I think the Leiden scores. Yeah, I mean, you want to calculate it. I think we need to come up with some automated measures. Right now, we're on the cusp of, developing a lot of deep learning techniques. They will get more and more accurate. I think it would be best if we came up with something very simple that you can visually see, and not a complicated score. Coronary calcium, I think, has its limitations. We didn't talk about this, but the density of calcium goes in the opposite direction from the volume. The less dense it is, the more risky the plaque. And, so I think there are limitations to the use of the coronary. It's stood the test of time. So who knows if I'll be right or wrong. But, I certainly think that, we are yet to develop, but probably none of those kind of measures would be what we really want.
Okay, well, thank you very much. That was wonderful. I really enjoyed it, and we'll hopefully keep the collaborations going.
Awesome. Remember for the COVID registry.
Please refer your patients.
Exactly. I was just going to say one last message to everyone connected. If you had any patient who had a CT before the COVID, whether that they got seriously ill or whether they escaped the pandemic, they are potentially recruitable for this trial. So we have a database and we're going through the database, but your word of mouth is actually very helpful to refer them.
Thank you very much. Well, have a nice and Friday. Thank you for taking the time.
Thank you for inviting me.
Bye-bye.